This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday morning conference. As you can see, today is Journal Club Day. We have two presenters. Today is per usual, both presenting articles from the New England Journal from October. Our first presenter is Dr. Nida Waheed. She's a third-year fellow in our clinical track, and she is going to talk about cerebral embolic protection during TAVR. So take it away, Nida.
All right, thanks, Dr. Williams. Good morning, everyone. Thanks for joining for Journal Club. As he mentioned, I'll be talking about the protected TAVR trial, which was one of the late-breaking trials presented at TCT in Boston this year, and it was published just a couple of months ago. This clinical trial evaluated the Sentinel cerebral protection device, which is a Boston Scientific device that's used to capture and remove embolic debris during TAVR. So just to dive into a little bit of background, we know that during the past decade, TAVR has transformed the treatment of aortic stenosis. And although there has been technological improvements, really refinements with technique and increased operator experience that have led to progressive reductions in most complications, peri-procedure stroke still continues to occur somewhere in the range of 2 to 5% of patients after TAVR. So this diagram depicts some of the mechanisms of acute and subacute stroke during TAVR. In illustration A, it depicts an acute embolization in which there's basically a disruption of the plaque whenever you cross the aorta or the aortic valve. And it's basically from passing the guide wires or large bore catheters at the time of the procedure. Illustration B shows that the device has been positioned in the aortic position, and it's been implanted, but there is a risk of thrombus formation on the catheter, and sometimes that can cause a stroke as well. There can also be subacute embolization. So basically there's a persistent nidus of calcium on the Nida valve leaflets, and that can provide a further source for embolization once after the valve has been deployed. So even in the absence of clinical symptoms, the majority of patients after a TAVR, so that's ranging between 70 to 90%, have defects that you can see on imaging after TAVR. And here you can see some of those lesions pointed out. Now, we know that strokes can be devastating, particularly after procedures too. The mortality rates have been shown to increase about 5 to 10%. Survivors are often disabled, and it dramatically increases length of stay, as well as medical costs. So this has really been a focus. And the trial that the Sentinel device that was initially published in 2017 led to the FDA approval after basically its safety and efficacy was proven during this trial. Here you can see that the Sentinel CEP device captured about 99% of debris in patients. And it did not change neurocognitive status. The device was safe, so there was no increased MACE after about 30 days between the CEP arm and the control arm. The primary endpoint in this trial was actually new cerebral lesion volume reduction, not necessarily stroke. And here you can see that there was actually no difference. But when they did a post hoc analysis, they did see that there was a trend towards reduced stroke after about 72 hours after the TAVR in the patients who got a CEP device. So that led to our current trial being conducted, and the purpose of it was to investigate whether CEP reduces the risk of peri-procedural stroke with TAVR, not just cerebral lesions. So the inclusion criteria for this trial included basically patients with aortic stenosis who were getting a TAVR via transfemoral access. And there were some artery diameter parameters that you can see here, basically making it so that the patient was not incompatible with the placement of a CEP device. There were some exclusion criteria. You can see the main one is the first bullet, which is arterial stenosis greater than 70% in either the left common carotid artery or the brachiocephalic artery, which are used to deploy the CEP device. The other few bullets are basically any kind of anatomical structure that would not cause the CEP device to be deployed. If there's any kind of bleeding disorders or contraindications to anticoagulation or antiplatelet agents. This was a prospective multi-center randomized control trial. It was randomized 1-to-1. It was stratified according to the center, operative risk, which ranged from low, intermediate to high, and intended TAVR valve type. So whether it was balloon expandable or non-balloon expandable. It ranged across 51 centers in North America, Europe, and Australia. And it was sponsored by Boston Scientific. So the intervention, so what exactly is the CEP device and how, what does it, where is it whenever the procedure is going on? So this device has 2 filters, which you can see here, and it's delivered through a 6 French delivery catheter. The filters are placed percutaneously from either the right radial or brachial artery into the brachiocephalic artery, which you can see here. And the distal filter is in the left common carotid, which is right here. So both of these areas are protected. As you can see, the left vertebral artery is unprotected. So there is a chance that there could be an embolic event through this pathway, but both of these are protected with this device. For this trial, all the investigators were experienced in deploying the Sentinel CEP device, which they defined as the operator having done at least 20 procedures. So the primary outcome was a clinical stroke within 72 hours after the TAVR or before discharge, whichever came first. They did have some secondary endpoints, including stroke severity, which was assessed using the modified Rankin scale, which is essentially a scale that's from 0 to 6, 0 indicating no symptoms and 6 is actually death. So usually it's actually scaled from 0 to 5, but we'll go into it a little bit more later. The other secondary endpoints were all-cause mortality, stroke, TIA, delirium, AKI, and vascular complications at this CEP access site. In terms of the statistical analysis and the enrollment number, they planned for the enrollment to hit at least 3,000 patients. They did do an interim analysis once 2,100 patients were enrolled. To determine greater than 90% power to demonstrate superiority of the CEP if the expected stroke rate was 4% in the control group and 2% in the CEP group. When they did the interim analysis, the stroke rate was actually 2.4% in the control group and 2.2% in the CEP group. And the Data and Safety Monitoring Board basically recommended that they finish recruiting for a final sample size of 3,000. And it was an intention to treat analysis. So here you can see that in the CEP arm, it was about 1,501 patients, and the control group was 1,499, so split evenly. Patients in the trial were generally representative of the overall population eligible for TAVR with CEP. The mean age was, as you can see on the first line, was 79. And one thing I just wanted to point out is that it did look, even though the trial was randomized, that there is a greater proportion of females in the CEP group. And in terms of surgical risk, it seems to be well balanced between low, intermediate, and high between the two groups. And the modified Rankin score was a balance between the two groups at the time of randomization. So what is the modified Rankin score? As I mentioned, it's a disability score, and it's widely used to report outcome measures in stroke clinical trials. This trial specifically had a neurology professional perform neuroexams on patients at baseline and after the TAVR was performed. And This trial defined a disabling stroke as anyone with a modified Rankin score of 2 or greater. So they had a slight disability to severe disability after the TAVR, or at least 1 point greater than their baseline. So getting to the results, as you can see here, there's no difference between stroke in either group. So it was 2.9 in the control group and 2.3% in the CEP arm. But they divided it into disabling stroke and non-disabling stroke. And even though the numbers are very low, if you move forward and do an analysis between the two, it did show that there was a significant difference between having a disabling stroke or not if a CEP device was used during the procedure. So there was a 60% relative risk reduction in a disabling stroke when evaluated. So the absolute numbers are low, and the number needed to treat to prevent one disabling stroke is about 125 patients. So looking at some other outcomes, we did talk about the primary endpoint already. It makes sense that there's no difference between hemorrhagic strokes in the two arms, but there is a difference between ischemic strokes because it goes with the mechanism of the CEP device in terms of catching embolic material during the procedure. No difference between major or minor vascular complications if the CEP access at the CEP access site. So no vascular complications if the CEP device was used. And just to quickly mention, in terms of secondary endpoints, no difference between TIAs, delirium, AKI. And then the modified Rankin score was also similar between the two, except for the disabling stroke component, which I mentioned earlier. So for this trial, so although it did not definitively identify a role for CEP in patients undergoing TAVR, the CEP device was safe and it was deployed successfully in 94% of the cases in this trial and may be a reasonable choice for some patients. There were fewer disabling strokes observed with the CEP device, but there was no specific subgroup identified which strongly favored who should use a CEP for stroke reduction and who may not need it. And just to note, this trial, although it enrolled about 3,000 patients, there is an upcoming trial, I think called the BHF Protect TAVI trial, which is an RCT also using the Sentinel CEP device that's similar to the current trial and has a projected enrollment of about 8,000 patients. So this trial brought up some interesting results. So that one should be able to help clarify some of the questions that came up. Now, there were some limitations to this trial. So despite the large number of patients and the use of randomization, the CEP group did have a greater percentage of female patients, and female sex has been reported to be a risk factor for stroke with TAVR. Another limitation is that although neurologists were doing the exams, they were not blinded to who was getting the procedure with the CEP device and who was not. And then obviously this is short-term follow-up within 72 hours, so long-term results would be helpful. Now, some people have interpreted this trial as positive because it reduces disabling stroke, and they consider that, and they've interpreted this to say that CEP should be considered in all patients, while others interpret this trial as a negative trial with CEP devices having less of a role with the TAVR procedure. So, here you can see a quote from Dr. Grubb, who's on the Emory structural team, saying that a disabling stroke rate of less than 1% is still an important finding that resonates with patients. And basically interprets that although, it basically justifies whatever the institution is doing. So CEP will likely justify practice with the reduction in disabling strokes, for centers that don't use CEP will point to the missed primary endpoint. So there is, a good discussion that kind of went back and forth between a lot of cardiologists once this trial was published. And you can see that the results of this trial have been conveyed differently in the media as well as with patients. So you can see this is the Boston Scientific way of conveying the results of this trial, basically saying that there's a 60% relative risk reduction in disabling stroke, whereas ACC reported it a little differently. And at PCT, it was interesting because 7 out of the 8 panelists voted yes to using the Sentinel device in TAVR procedures to prevent disabling stroke. So although, quote unquote, it's regarded as a negative trial, I think the results have been interesting and have kind of laid the groundwork for the subsequent trial that's going to follow that enrolls 8,000 patients, and it's been a good discussion so far, I think, amongst the cardiology community. So that's the overview of the trial. I appreciate your attention, and I'm happy to take any questions.
Thank you, Nida. Good summary. Yeah, you're right. I mean, it's a bit of an eye of the beholder study, but it seems like overall a neutral or negative. Now, in terms as I'm looking at the subgroup analysis, even and I imagine they were sort of leaning hard on, well, maybe it's not best for everybody, but best for certain. Even if you look at the subgroup analysis, it didn't really, there's actually a trend towards more help in younger patients, which I guess would have been a little bit surprising, et cetera. But I guess what would be your take home on this? Is like useful, not useful, useful in some patients? What would be your take home message?
Yeah, no, I think that's the question everybody wants to know. I think my interpretation was it's promising, and I think there is a group of patients that we need to identify that would really benefit from this. How would we evaluate and figure out that patient population? I'm not sure, but one thing I thought was interesting was the safety profile for the CEP device was really good. So I think if there's no harm and it doesn't, it's a pretty, quick procedure to do before a TAVR, then erring on the side of preventing a disabling stroke might be worth it, especially since TAVR numbers are going to be going up. So I know the number needed to treat is 125, but I think I think I would lean towards it going forward.
And it's actually interesting if you look at the subgroup analysis, the data from the United States. If you look at the United States versus, like, it almost achieved significance.
It almost achieves a significance.
International data that was actually
yes,
almost favoring not using it. That sort of swung things the other way. Yeah.
So I think what you're referring to, there is a part in the table where then basically it's like 2.6% of patients in the control arm and 1.3% in the CEP arm, and it's in the United States.
Essentially twice as many strokes in the
essentially
arms, 24 versus 12.
Exactly. Yes. So I think it's probably largely due to volume and operator and kind of the program, and the programs that do it, like higher volume versus not. But that was interesting to me too, but it didn't quite, it's almost achieving significance, but it'd be interesting as kind of we move forward. I think the other trial is actually being done in Britain, so it'd be interesting to kind of compare those results to and see if it follows the other or the United States trend.
Other questions, comments from the group? All right. Well, very good. Need any other comments, closing thoughts?
No, I think it was. It's just I thought it's just a interesting way how people have interpreted it. So it'll be good to see what the next trial shows too.
Yeah, I
Thank you.
agree. It's in the eye of the beholder. Thank you, Nida. Yeah, I agree. I think moving forward, it'll be like sort of patient selection. I think will be the
main,
possibly showing some benefit.
yeah.
So
Yeah, agreed. Well, thank you.
our next presenter is Dr. Aneesha Thobani, a third-year fellow, also in our clinical track, also presenting a recent article from the New England Journal, which looks at, as you can see, racial and ethnic differences in CPR for witness cardiac arrest. Interesting study. Take it away, Aneesha.
Awesome. Thank you so much, Dr. Williams. And thank you everybody for joining. Awesome presentation, Nida. I'm taking it a little different way, moving away from drug trials and going into a little social determinants of health sector. So I hope everybody will enjoy this and it will lead us to having a good discussion. This study actually just came out 2 weeks ago, was published on October 27th in the NEJM, and I also want to thank Maya for bringing my attention to this study. A couple of reasons I chose this study. I think with us, especially providing care at such a large community hospital at Grady, it's good for us to check our own biases and understand social determinants of health. The inspiration for choosing this also came from one of my Grady clinic patients whom I saw a couple of weeks ago. It's a 33-year-old Black male who had a PA arrest in the field and did not get timely CPR. He was at home and his girlfriend didn't know what to do. He ended up with anoxic brain injury and TBI from it. And now he's trached and pegged, he's wheelchair bound, he's minimally interactive with his family, and his mom has become his caregiver. And just with him being so close to my age, and it really kind of struck a heartstring and made me think, what if there was plenty of education and training for CPR, potentially his family could have started this sooner and averted such adverse outcomes. Also at just last weekend's AHA meeting, the president, Michelle Albert, she very eloquently spoke about social determinants of health and the connection between adversity and cardiovascular health in her opening remarks. And this quote from her really resonated with me. We need not let people die from the effects of economic adversity. So I think as physicians, we have a responsibility towards this as well. A little bit of background, as we all know, CPR performed by bystanders increases the odds of survival for people with out-of-hospital cardiac arrest. Racial and ethnic disparities in survival for out-of-hospital arrest have been reported. However, prior studies and reports on the differences in bystander CPR according to race and ethnic group have not really looked at witnessed arrests, and a lot of the data is for unwitnessed arrest. Up until this paper, it was unknown whether differences exist only in the home setting versus also in public locations, how often bystander CPR is initiated. And understanding the magnitude of racial and ethnic differences in bystander CPR according to the location of the arrest could guide policies to improve the incidence of this potentially life-saving intervention. The study question is, what are the racial and ethnic differences in layperson-initiated bystander CPR for witnessed out of a hospital cardiac arrest at home and in public locations? The authors of this paper hypothesized that Black and Hispanic people with out-of-hospital cardiac arrest would be less likely to receive bystander CPR at home, given the lower incidence of CPR training in their communities. They predicted that the treatment difference would actually be smaller for cardiac arrest that occurred in public locations, where potentially there would be more bystanders around who could initiate CPR. The independent variable here is obviously race, and the primary outcome is initiation of CPR. How they collected their data. This was a retrospective analysis. They used the CARES registry. This registry is the cardiac arrest registry to enhance survival and it was actually established by the CDC and here at Emory. It includes a catchment area of approximately 167 million residents in the United States, representing about 51% of the population. And everybody who had a non-traumatic out-of-hospital cardiac arrest in whom resuscitation was attempted is listed in this registry. Found this map in the supplemental materials, and this is a representation of what states participate. So the blue states here all participate in the CARES registry, and the white states don't. It's interesting to see that Georgia does not participate, and this was actually established here at Emory and the CDC. Not quite sure why that is, but at least we do, have 51% of the US population represented. So the study cohort, they identified 460,000 out-of-hospital cardiac arrests that occurred from 2013 to 2019. About half were excluded as they were unwitnessed arrests. 12,000 excluded as they were pediatric. Further were excluded if they were witnessed by EMS or first responders, as they're not classified as bystanders. And then about 23,000 occurred in the nursing home or healthcare facility, which were excluded. Out of the witnessed cardiac arrests, that were 146,000. Just to make sure their analysis what they were looking for, they excluded about 30,000 whose race or ethnicity was not known, close to 5,000 who were listed as either Asian or Native American patients. They did do a further secondary analysis on this group, and about 872 did not have any census tract information, and those were arrested, and then just a few for missing data. So the final cohort ended up being about 110,000 witnessed out of hospital cardiac arrests in Black, Hispanic, or white people. The study outcomes, the primary outcome is initiation of bystander CPR, defined as CPR initiated by any layperson, whether it be a family member, medical provider, or other person who was not a 911 responder, fire, police, or EMS employee. Looked at home versus public location, and analysis was further stratified according to the racial or ethnic makeup and the income composition of the neighborhood. They used census tract as proxies for neighborhoods. So neighborhoods that were classified as predominantly white, where more than 80% of the population listed themselves as white. Majority Black or Hispanic, where more than 50% was self-reported as Black or Hispanic or integrated. So these were the three groups for their neighborhoods. And then neighborhoods were also classified in income stratifications. So high income, where the median annual household income was greater than 80,000. Middle income was 40 to 80, or low income was less than 40. All statistical analysis was multivariable hierarchical logistic regression models, adjusted for race, age, gender, and cause. They analyzed also types of public locations, which we will look at, and then two additional things they looked at were survival to hospital discharge, as well as favorable neurological survival or recovery. Getting to the results, so of the total 110,000 witnessed out of hospital cardiac arrests, 32% occurred in Black or Hispanic people, specifically 24.7 in Black and 7.5 Hispanic. Overall, there were more arrests happening in the home setting compared to public locations. That was 76.6% versus 23%. Now, these are the stark differences that caught my eye. Black and Hispanic people were less likely than white people to receive CPR at home, 38.5% versus 47.4%, with an adjusted odds ratio of 0.74. And you can see the confidence interval is very stringent. And then in public locations, which is a pretty big difference, 45.6% versus 60%. And again, that confidence interval is very small, 0.6 to 0.66. Black and Hispanic people had a lower incidence of survival to discharge as well, and a lower incidence of favorable neurologic recovery. And they were also less likely to receive bystander CPR in every public location category that they looked at. Here's a quick table of demographics and characteristics of the cohort. Age, we can see that, well, let me just kind of clarify. The first column is all people with cardiac arrest, the middle column is Black or Hispanics, and the far right column is white people. For age, we can see Blacks or Hispanics were younger, and as far as gender goes, more females were likely to have cardiac arrest that they did not receive bystander CPR. The middle few rows are the race that we have talked about. And then interestingly, they also looked at the types of people initiating CPR, and in all categories from unspecified layperson to family member, it's lower in the Black or Hispanic group. And then when you look at first responder and EMS, if you can follow my cursor, it's about equivalent to slightly higher in the Black Hispanic group. Moving on, bystander CPR and people witnessed out of hospital cardiac arrest. So this is the main results table stratified for the racial or ethnic makeup of the neighborhood, as well as median household income. We've already talked about this. Overall, at home versus in a public location, comparing the Black or Hispanic group to white people group, we can see lower in Black or Hispanics at 38.5% versus 47.4%, and then in public locations, 45 versus 60. Across the board, when you go down these rows, for majority white neighborhood, for majority Black or Hispanic neighborhood, or integrated, the numbers are lower in the Black or Hispanic group versus the white people group. I circled this middle thing because it was interesting to me that even in neighborhoods that are majority Black or Hispanic, they were still less likely to receive bystander CPR, with differences at home of 37.3% versus 43.4%, and in a public location, 41.7% to about 55%. Looking at median household income of neighborhood and the socioeconomic status, again, for all income levels, there's a difference, and it points to lower for Black or Hispanic people, and I won't go through every row right now. I'll give you a second to kind of look at that. When stratified by types of public location, in the workplace, on streets or highways, and recreational facilities and public transportation centers, again, we see that Black or Hispanic people were much less likely to receive bystander CPR. It's interesting to me that in recreational facilities and public transportation centers, which you assume are heavily populated and a lot of people around, and the differences are pretty stark. For recreational facilities, it's about 56% to 74%, and in public transportation centers, 48% versus about 70%. Here's one of the secondary analysis looking at survival outcomes for witnessed out of hospital cardiac arrest. So survival to hospital discharge, comparing people when had cardiac arrest at home versus in a public location, Blacks or Hispanics had a lower likelihood of survival, 11% versus 12.5, and then 22 versus 31 in the public location. And then secondly, looking at favorable neurological outcome, again, it was lower in the Black or Hispanic group, 7% at home and 17.5% in the public location, comparing to the white group. I was also interested in looking at the supplementary materials into what the causes of the cardiac arrest were and whether they were different across the racial groups. And interestingly, there's not much difference. Most of the arrests occurred and were presumed to be cardiac, pretty equivalent in both groups here. Second was respiratory, then drowning, drug overdose, electrocution, and then hemorrhage. So these numbers don't vary much. So the reasons for the cardiac arrest weren't different. So kind of thinking about this and getting into the discussion part, the relative likelihood of receiving bystander CPR at home was 26% lower for Black or Hispanics and 37% lower in public locations. I think it is kind of well known that CPR training is less commonly conducted in Black and Hispanic communities, and dispatcher-assisted bystander CPR may not be as readily available. These differences in neighborhoods may be the consequence of structural racism that still exists today that has led to unequal investments in CPR training and community infrastructures. Additional barriers that I was kind of thinking about include cost of training and resources, obviously, especially in the lower socioeconomic neighborhoods. Language barriers is a huge thing in Black and Hispanic neighborhoods. Immigration status concerns and lack of trust in public institutions such as the police, and just fearing these institutions, and the fear of being sent back could be prohibiting some people from seeking out training or participating in training. The differences in public locations, like we looked at public transportation areas and recreational facilities where you would expect more people to be around and more willing to start CPR. These differences, may be due to implicit or explicit biases. Especially implicit bias stemming from public safety concerns may deter, this bystander response for a Black or Hispanic person who's having a cardiac arrest compared to a white person. And police and healthcare staff workers have been shown to harbor bias in their views and treatment of Black and Hispanic people in multiple healthcare settings as well. Now, what can we do to resolve this and move towards a more equitable society? To mitigate these racial and ethnic differences, I believe it will require a multifaceted approach. There is a critical need to offer low cost or no cost CPR training in Black and Hispanic communities, and to have these trainings in more convenient and accessible settings, such as Black churches or Hispanic community centers. It's also important that we use linguistically appropriate and culturally sensitive CPR training to effectively reach these diverse communities. On a governmental level, it's important to prioritize funding for dispatcher-assisted CPR, including, diverse languages in Spanish or African languages in these neighborhoods, which can help. CPR training materials like mannequins and videos that actually portray people with cardiac arrest and bystanders as a diverse and multicultural population is also important. Implicit and explicit bias training in workplaces and healthcare settings and governmental institutions, and having readily available AEDs in public locations, and that goes with training in these communities. This study has a few limitations. There was no information on the race of the bystanders available that could help show whether bias actually contributed to differences in bystander CPR in public settings. This is something we are presuming. There was also no information on number of laypersons available to respond, whether there were a lot of people versus few people, and that contributed to the different numbers that we're seeing in the public settings. There's also no information for why bystanders did not participate. I think that would also be hard to get. There also can be misclassification of race and ethnic groups in some cases reported in the CARES registry, so you have to be cognizant of that. And these findings may not be generalizable to all regions, especially rural areas or states that do not participate in the CARES registry, as this only looked at data that was in the CARES registry. Further research is needed in this area, and I think it'll be interesting to look at other races and if there's other racial differences as well. So in summary, the relative likelihood of receiving bystander CPR at home was 26% lower and 37% lower in the public locations. And a multifaceted public health interventions are needed in training and education in communities. And as an academic institution, we must be aware of these differences and we should check our own biases. And I think the first step is always awareness and education. So thank you so much. Happy to hear what your thoughts are.
Thank you, Aneesha. Good summary. Yeah, that's a rough one. I don't have a whole lot to add to it. I think it was an excellent summary, and yeah, just sort of a sort of difficult one to swallow, unfortunately, as healthcare provider. Anyone else comments?
Hey, Anita, this is Madeleine. Thanks for highlighting this. Yeah, but one of the things I want to mention, you in your summary, you call it differences. I think that as we think about equitable care for everyone, we have to, what you described, in my opinion, and I don't know, I'll be interested to hear your thoughts, are not racial differences. These are disparities, right? So these differences are not, and we can even take it further and say that these are inequities, because I think that as we think about achievable equitable care, we have to move from a passive discussion, a passive description of what we observe to a more thought-provoking approach. You highlighted all the things we should think about. You know, I think another thing to think about, and you mentioned it as well, is like language competencies and all of that. But is it something that on a national level, AHA can think about offering CPR in languages that people understand? You know, I think that all the points you highlighted, taking care, as we address social determinants of health, you have to take care to where people work, live, play, pray. You know, that is where you'll address social determinants of health. So thank you for highlighting this. I think that it's thought-provoking, and I think as individuals, as communities, as professional organizations, it's something that we really need to focus on. Thanks.
Yes, ma'am. Thank you so much.
Dr. Dickert had his hand up.
Yeah, can you guys hear me? I can't tell whether I'm muted or not.
Yes, we can hear you.
Oh, okay, perfect. So thanks so much for presenting this piece. It's really important as it's, you know, one of the sort of public health aspects of things that we all take care of and are responsible for communicating the importance of. So it's a really important study. So one thing you mentioned, and I just would underscore it, right? So the CARES registry, which Brian McNally at Emory, you know, heads up, is you highlighted the fact that it's underrepresentative of the population. That's largely because it's been unsupported, underfunded, and you know, I think this shows the importance of better support for things like this. So you kind of highlighted the importance of that. It's not something that we as individuals can necessarily do, but I think, you know, increased funding and support for registries like this is really important, in part because, you know, the second piece that I would raise is that you mentioned that one of the things that the limitations of data like this, it's hard to tell whether we don't know enough about each of these settings, right? So how much of the solution is we just need to increase training broadly so that we're not in situations where people are in environments where they're less likely to get CPR, how much of this is, you know, the resources available to people who are calling in terms of dispatcher CPR, you know, all the granularity needed to get at what, you know, at ways to make a dent in this, you know, it's hard to have without better support for registries like CARES, and they do really important work. And you know, we need more data to figure out how best to tackle this. Really, you know, it's a big public health problem, and you know, you highlighted a lot of the potential avenues to get at this, but which ones are going to be the highest yield and which ones are going to be, produce the best public health gains for people who currently aren't having access to appropriate care. It'd be nice to have better data.
Yeah, I definitely agree with you. And I think one thing that I always think about is government funding for a lot of public health issues and how to kind of advocate for that, and how as physicians with a limited time we have, how can we get involved with that? And I personally still struggle with that. And I think it's a personal journey as well.
Yeah, this is one just for people who don't know. My understanding for CARES, I don't work with CARES data. I don't know a lot about the registry itself, but my sense is that this is really a sort of a voluntary thing for EMS systems and states to contribute to this. So they're not required to do it. They're not funded or supported to do it. It's really about whether or not they take this on to report their data. And so obviously that imposes limitations both in terms of coverage and data quality. And everybody's trying to do the best they can with what they have. But we need better evidence.
Mm-hmm.
All right, other comments, questions? Okay.
I would just add one more plug for this in terms of getting it, thinking about, in addition to the benefits of having better evidence for figuring out sort of big public health interventions, understanding, we have a poor evidence base for a lot of our practices in terms of the emergency medical setting to start with, and the better registry data we have, the better we can learn about how to refine our sort of practices for resuscitation and whatnot.
All right. Well, again, I want to thank Nida and Aneesha for presenting those two very interesting studies today, articles, and thank everyone for tuning in, and look forward to seeing everybody. Yeah, I guess we're still on next Friday, and then we'll be off the following Friday for Thanksgiving, obviously. So see everybody next Friday.
The preceding program is copyrighted by Emory University.